This was a 58 years old female patient with moderate primary open-angle glaucoma and cataract on 2 anti-glaucoma medications with an intraocular pressure of 26 millimeters of mercury. Her discs and Humphreys visual fields were as shown here. We planned for phacoemulsification with IOL implantation with Stent Inject implantation for her. A standard phacoemulsification was performed and the intraocular lens was implanted in the bag. Intracameral pilocarpine was then used to constrict the pupil, and the anterior chamber was filled with Helon-GV. iStent Inject is the smallest implantable device in the human body with a length of 360 microns and a diameter of 230 microns. It is inserted by an injector device through a clear corneal incision into the trabecular meshwork under direct visualization through an eye prism. 2 such stents are injected 5 to 6 clock hours apart. The preloaded device has 2 eye stents and 4 charges to release them. After placing the gonio lens on the cornea, the trabecular meshwork was carefully visualized. The injector was introduced into the AC and the sleeve withdrawn. The trocar is used to indent the trabecular meshwork slightly, and then the first shot was released. To my surprise, as I withdrew the trocar, the eye stent was clearly seen undelivered and unreleased from the trocar flanges. The second and the third attempts met with a similar fate. On top of that, the bleeding from the trabecular meshwork was another hindrance, obscuring the visualization of the implantation site. This was an unique situation, as it was quite clear that this is a malfunction of the trocar flange release system. However, fortunately, we were extremely lucky to have another iStent Inject with us in the OT. Normally, we don't. So, we changed the iStent Inject system. After thorough wash with irrigation aspiration and tamponade with Helon-GV, I went in with the new iStent injector. A hassle-free implantation of the first iStent, followed by the second one 5 clock hours away, was possible. The patient, after 8 months of follow-up, is maintaining 18 millimeters of mercury intraocular pressure on a single anti-glaucoma medication with stable visual fields. This unique complication shows that even though it is a costly implant, the surgeon should always have a replacement at hand to ensure that the planned procedure does not have to be aborted due to instrument malfunction.